having a good start to the day. Thank you for tuning into our brand new webinar series, Clinical Anaerobic Bacteriology. We're delighted to start this series by welcoming Dr Shenoy, Associate Professor of Microbiology at Kasturba Medical College in Manipal, India. Padmaja's talk is titled Antimicrobial Resistance Trends in Anaerobes. Antimicrobial resistance poses a significant threat worldwide, and although often overlooked, anaerobes play a significant role in its spread. Identification and susceptibility testing has evolved considerably, but this has revealed rising resistance patterns and highlighted the importance of routine culturing and testing of anaerobes to help minimise the spread of resistant strains. Padmaja has more than 14 years of diagnostic experience in the field of clinical microbiology. Her prime area of research is in the field of anaerobic bacteriology, with special emphasis on antimicrobial resistance among anaerobes. Padmaja has conducted several intramural and extramural research projects targeting antimicrobial resistance among anaerobes and gut microbiome profiling. We're excited at Don Whitley Scientific to bring you this webinar on antimicrobial resistance, which is of great importance to us. If you have any questions, please leave them in the chat box and we will answer them at the end. Thank you, and we hope you enjoy the webinar.
A warm welcome from Kasturba Medical College, Manipal. Today I will be discussing antimicrobial resistant trends in anaerobes. This will be the overview of my presentation. Anaerobic bacteria are the part of normal flora of human skin and mucosal membranes. The site of anaerobic infection is commonly the site of normal colonization. Diverse diagnostic methods are available to identify them, and these methods ranges from conventional culture techniques to molecular methodologies. Often overlooked in diagnostics, routine diagnostics, they are still the key pathogen in most of the serious or life-threatening conditions. Anaerobes are often associated with deep-seated infections like brain abscess to life-threatening conditions such as gas gangrene and bacteremia. Anaerobic infections are always polymicrobial in nature, so that complicates the therapy and requires immediate empirical coverage. So if you look at the frequency of isolation of the anaerobic organisms, gram-negative organisms are more commonly isolated than gram-positives in routine cultures. Among the gram-negative key pathogens, Bacteroides fragilis group is the most important clinically significant anaerobic organism, often associated with complicated intra-abdominal infections and bacteremia. Apart from that, we do have Clostridium species, of which Clostridium perfringens responsible for causation of gas gangrene, and Clostridioides difficile is associated with nosocomial diarrhea. Apart from this, we do have Prevotella, Fusobacterium, Peptostreptococcus anaerobeus, and Feingoldea magna, which are associated with infections of respiratory and genital infections. In anaerobic infections, a poorly collected samples tells you more about the air than the organism. Yes, you heard me right. That means if you want to isolate the organism in pure culture, anaerobic organisms in pure culture, you need to collect the right sample at the right time. Our main aim is to prevent the colonization or contamination with the normal flora. So this slide highlights different samples which can be collected from diverse infections where you are suspecting anaerobic etiologies. Certain samples like swabs, if you don't have any transport media available, better not to consider swabs for anaerobic culture. Expectorated sputum, voided urine sample are also not acceptable samples. Stool specimens can be processed only for the Clostridioides difficile culture, not for routine anaerobic culture. So once we collect the sample, make sure that you do not expose the sample for oxygen. If you're collecting the sample in a sterile container, the aim should be that you should transport the sample immediately to the laboratory and immediate processing has to happen. If there is some delay in transportation, then consider transporting the sample in the commercially available transport media. In low middle income countries like India, we don't have transport media. So what we make use of is Robertson cooked meat broth or thioglycolate, which do not act as a transport media, but it's a kind of enrichment media which will help you in preserving the viability of the organism. So once it reaches the laboratory, make sure that you do not refrigerate any samples and process the sample immediately on respective culture media. There are a lot of culture medias available. You can make use of neomycin blood agar or brucella blood agar or Schindler's agar can be used. So other than this, you have certain commercially available PRAS medias also. So the processing has to happen under anaerobic condition, and the plates also has to be maintained in the anaerobic condition. Remember to incubate the plates for minimum of 5 days, because there are some virulent and slow growing organism which will show up in culture only after 4 days. So if you are dependent on anaerobic jar system to obtain the anaerobic condition, in such cases, if you want to know if your anaerobic condition is maintained right or wrong, so in such cases you can do the performance testing using the ATCC strain. Let's begin with the clinical scenario. We have here a 56-year-old diabetic man who came with the complaints of headache and swelling in the right side of the head. So for 18 days. 4 months back, he was diagnosed with grade 2 right frontal atypical meningioma, and for which he had to undergo right frontal craniotomy with Simpson's grade 2 excision. So following which he was on radiotherapy as per the management protocol. There was no history of any fever, vomiting, nausea or visual disturbance. On admission, the patient was conscious, oriented to time, place and person, and he was obeying to the oral commands. On examination, there was reduction in the power of the left upper and the lower limb, and also there was swelling which was observed in the frontal area. When the MRI was performed, so he was diagnosed to have subdural empyema. At this time, his blood parameters, there was increase in the leukocyte count with neutrophilic predominance, and immediately he was taken up for right frontal craniotomy and the abscess drainage was done. So at this time, he was started on ceftriaxone and metronidazole. The sample reached to our lab where we subjected the sample to gram stain and we cultured it on aerobic media like blood agar and chocolate agar, which showed no growth even after 48 hours. Similarly, the sample was processed for anaerobic culture, so where we could observe small grey white opaque edge colonies which were resistant to metronidazole, and spot indole was positive. So this growth we could observe only after 4 days of incubation. So we identified this isolate as Cutibacterium acnes. So the report was communicated with the neurosurgery team, and immediately metronidazole was stopped for this patient and he was started on ceftazidime and linezolid. And he was also discharged with ceftazidime and linezolid, and his follow-up visits were uneventful. So if you look at this case, why did I discuss this case? Mainly, one has to remember that gram stain can help us in diagnosis of some anaerobic infection. Also, prolonged incubation of culture helped us to identify this slow growing organism. So, and also one more thing is that the Cutibacterium acnes could be a normal flora, but due to surgical intervention, the organism could have got access into the central nervous system, resulting in subdural empyema. So, sample collection and the procedure, everything has to be done in a right way. So, as we are witnessing, there is a surge in virulent and new anaerobic species. So even after surge in the anaerobic species exist, so the treatment for anaerobic infection has long been empirical, so which has led to therapeutic failure in many cases. Not many laboratories perform antimicrobial susceptibility testing on routine basis. And also we are witnessing dynamic changes in the antimicrobial resistance in anaerobic organism. So before discussing the antimicrobial resistance in anaerobic organism, let's have a look at different antibiotic classes which can be, which are having anti-anaerobic activity. So we call old is gold. Nitroimidazole group of antibiotics that consist of metronidazole and tinidazole. Metronidazole may be old, but in the anaerobic world, it's still holding the front line, though not without cracks. So it is still considered as one of the wonder drug which acts against most of the anaerobic organisms. But we do have to remember there are certain organisms which are intrinsically resistant to metronidazole also. So if you link this sentence with my case, what I had presented. So if you'd seen the culture plate, the Cutibacterium acnes was resistant to metronidazole in culture, right? So there are certain organisms which exhibit the intrinsic resistance also. So apart from that, we have beta-lactam group of antibiotics. So beta-lactam antibiotics consist of penicillin group of drugs, so which are having minimal activity against the gram-negative anaerobes, whereas this can be used against the gram-positive anaerobes in some cases. So apart from penicillin group of drugs, we do have cephalosporins. So among the cephalosporins, the third generation cephalosporins like ceftriaxone, cefotetan or cefotaxime are having some anti-anaerobic activity. So apart from this, we do have beta-lactam, beta-lactamase inhibitor combination. We call it as BL-BLI combination. So like your piperacillin tazobactam. So this drug has been used in many cases whenever you come across complicated conditions like complicated intra-abdominal infections, etc. So it is very promising in such cases. So apart from this, we do have carbapenems. Carbapenems includes mainly imipenem, meropenem, ertapenem and doripenem. They are having very good activity against most of the gram-positive and gram-negative anaerobes. Among the quinolones, we have moxifloxacin and delafloxacin, which are known to have gram-negative activity. So apart from this, we have sitafloxacin, which is a newer quinolone group of drug, which is known to have anti-anaerobic activity, but studies are still lacking. So apart from this, we do have clindamycin. Clindamycin, once it was considered as the empirical drug in treating anaerobic infection, but looking at the resistance rate, now it is no longer considered as the empirical drug for the suspected anaerobic infection. So these are the other group of antibiotics which are known to have anti-anaerobic activity. So AMR is on track to become the next global pandemic, slow, silent and deadly by 2050. The world is watching rise in AMR in aerobes, but ignoring anaerobes where the resistance is rising but unreported and unrecognized. A European study, with a 20-year European study on bacteroides underscores silent but steady increase in rise of antimicrobial resistance. There are studies which highlights the emerging threats. So MDR is no longer, MDR is no longer rare in anaerobes. It is rising. It is reaching the clinical frontline. So antimicrobial resistance in anaerobes, most commonly discussed organism is Bacteroides fragilis group. As I've already mentioned, penicillin group of drugs are having minimal activity against the Bacteroides fragilis group because of the production of the beta lactamase enzyme. So carbapenem resistance, again, it is linked to expression of this CFIA gene, which is a metallo-beta lactamase, and expression is often regulated by insertion sequence. Reports vary regionally, but carbapenem resistance remains uncommon overall, restricting to less than 2 to 5%. However, there are some centers which are reporting slight increase in the resistance rates in their setup. So if you look at the metronidazole resistance, Bacteroides fragilis, the metronidazole resistant rates are quite less in Europe and US. But Prevotella species is one group of organism which is showing variable resistance rate. So let's look at the metronidazole resistance mechanism. Metronidazole resistance can happen because of the decrease in the uptake of the drug or increase in the efflux or decrease in the drug activation or because of the presence of DNA repair enzymes or specific resistant genes like NIM gene. So when we discuss the metronidazole resistance mechanism, we do have to remember there are some organisms which are intrinsically resistant to metronidazole like Actinomyces species, Cutibacterium species and Propionibacterium species. NIM genes. So NIM genes, mainly the nitroimidazole reductase that converts the nitroimidazole into aminoimidazole, which inhibits the formation of the free radicals. It's a family of 12 genes ranging from NIM-A to NIM-L, which may be chromosomally located or harbored by plasmids. Long-term exposure to metronidazole can lead to expression of therapeutic resistance in these strain with silent NIM genes. That means if you do the phenotypic AST, the organism may have susceptible MIC, but if you do the PCR, still the susceptible isolate may express this silent NIM genes. So the incidence of resistance in Bacteroides fragilis ranges, or globally I'm talking about, like it ranges from, the resistant rate ranges from 0.5 to 30%. So this table highlights different NIM genes expressed by different anaerobic organisms. So this table is telling us about the expression rate of NIM genes, particularly reported by different authors in their studies. So let's look at the geographical variation in metronidazole resistance among the anaerobes. So if you see this table, you can see there are some centers where they have not come across any resistant strains. So for example, there is a study which is a multicentric study which was conducted in 2021 where they tested 518 Prevotella species, but none of the isolates were found to be resistant to metronidazole. Similarly, in Netherlands and China, the resistant rate was less than 3% and less than 1%. So similarly, there is one more study which is conducted by ECMID study group on anaerobic infection. So where they included 10 different countries and they came across resistant rates of metronidazole in Kuwait to be 6.5%. So a study which was conducted in Italy is having a resistant rate of 30.07% among the fine Goldia magna. And another study which was conducted in Italy in 2023, again they came across around 18.2% of the fine Goldia magna isolates were found to be resistant to metronidazole. If you see, different places are having different resistance rates in their setup. So there is no uniformity at all. So it varies from place to place, center to center, and within the country, again hospital to hospital, there is difference in the resistant rates. This table highlights the metronidazole resistant rates in India. So there are several authors where they have conducted the agar dilution or e-test method of determining the MICs, and they have come across different resistant rates. So the studies which was done in our center, so we have conducted two studies on Bacteroides species and fine Goldia magna. So our metronidazole resistant rates in our setup is less than 8%. At the same time, there are studies which is done in other parts of India, so where they have come across 30.8% of the resistance rate in their setup. Another study which was done in 2025 on Bacteroides fragilis group, they have reported around 26.8% of resistant rate in their setup. Let's move on to clindamycin resistance in anaerobes. So what are the mechanisms which are responsible for clindamycin resistance? So three classic mechanism of drug resistance includes inactivation of the drug, altered permeability, and altered target site. There's something called as MLS, that is macrolide lincosamine streptogrammin resistance. So Bacteroides fragilis, so these three MLS resistant genes are present. So rapid increase in the clindamycin resistance in Bacteroides fragilis. So it is no longer considered as, the clindamycin is no longer considered as the first line therapy. So if you look at the global resistance rates of clindamycin, worldwide there are higher rates of resistant rates. So there are some studies where they have come up to 50% of the Bacteroides fragilis isolates being resistant to clindamycin. Mainly this resistance mechanism is mediated by gene, which mainly causes methylation of ribosomal RNA. So there are some studies which are conducted in Europe where they have come across 25 to 45% of resistance of clindamycin resistance in their setup. North America has reported around 20 to 30% of resistance in their setup, whereas some Asia Pacific the centers have reported more than 50% of resistance rate in their setup. So this table gives us the clear idea of different resistance rates of clindamycin in different centers. So there are some centers like Netherlands and Poland where the resistance rate clindamycin resistant rate is less than 33%. At the same time, so you have one study here conducted in China, so where they have come across 89.9% of the Bacteroides fragilis isolates being resistant to clindamycin. So you can imagine, so compared to metronidazole, clindamycin resistant rate is on rise. So again, the study which was conducted by study group on anaerobic infection in 2020 involving 20 different countries, there also Kuwait and Belgium has come across a resistant rate of 42% and 84% in Bacteroides species. And Kuwait has also reported a resistant rate of 89.2% in Prevotella species. So Italy, The resistant rates ranges from 35 to 44%. Similarly, among all the isolates, like in southern Spain, Fine-Goldia magna was found to be resistant to 54% to clindamycin. So this table highlights the clindamycin resistant trends in anaerobes in India. So in our setup, the studies which are done in our setup, so we have come across clindamycin resistant rates of less than 32% in our setup. So whereas there are studies where they have come across more than 50% clindamycin resistant rates in Bacteroides species. And one more study, that is Sood et al. Has highlighted that overall clindamycin resistance rate among the anaerobes was found to be 42.6% in India. Beta-lactam antibiotics, as we all know, nearly like universal among the bacteroides is the penicillin resistance is due to production of this beta lactamase enzyme, and it's not an reliable treatment except in fully susceptible anaerobes like some gram positive cocci. So this beta lactam resistance is often associated with the expression of CFXA and CEP-A gene, which confers higher resistance to penicillin and cephalosporin. So CFXA gene is an indicator of beta lactamase production, and beta lactamases are produced by CEP-A gene in Bacteroides fragilis. What is more worrisome is that anaerobes, they have come across zinc metallo-beta lactamases which are encoded by CCRA and CFIA genes, which hydrolyze carbapenem, imipenem, meropenem, and ertapenem in Bacteroides fragilis. So if you look at the global resistance data, the carbapenem resistance in Europe is less than 1 to 2%, and in US it is again less than 1%. Whereas there are some isolated reports, higher rates of resistance have been reported from some Asian and East European countries. So this table highlights, so this is again, I was discussing about the SGUI study group, which involved 10 different countries. So there they have come across penicillin resistance of 90.6% in Turkey, and 100% isolates were resistant to penicillin in Kuwait. Whereas meropenem resistance rate was found to be 9.6% in Kuwait and 4% in Belgium. So this table highlights the geographical variation in BL-BLI combination, that's your beta-lactam, beta-lactamase inhibitor resistance among the anaerobes. So in our setup, we had conducted a study on Bacteroides fragilis, and none of our isolates were found to be resistant to piperacillin tazobactam. Whereas a study conducted in China have come across around 21% of the Bacteroides fragilis isolates to be uh, resistant to piperacillin tazobactam, and around 28.7% of the Bacteroides fragilis isolate to be resistant to ampicillin sulbactam. So a study conducted in Greece, they have come across around 24.6% of the Bacteroides fragilis group being resistant to piperacillin tazobactam. And to mention, there is one study which is conducted in India, so where they have come across 27.5% of the anaerobic gram-negative bacilli being resistant to piperacillin tazobactam. So when we talk about the quinolone resistance, so most commonly the study has been conducted on moxifloxacin resistance. So again, the moxifloxacin resistance varies from place to place. Some authors have reported 36.4% of the anaerobic isolates being resistant to moxifloxacin. Whereas the study conducted in our setup, we have come across around 8.6% of the Bacteroides species being resistant to moxifloxacin. So there is surge or increase in the emergence of this MDR strain. The reports of Bacteroides fragilis strain being resistant to carbapenem, clindamycin, metronidazole is on rise. If this scenario happens, then we are left with nothing for treatment. So we have very limited treatment options. Why anaerobic AST is often neglected? Traditionally, there is a belief that, as I mentioned, old is gold. Metronidazole can be given to any of the suspected anaerobic infection and it works wonder in many cases. But we do have to keep in mind that the resistant rates to metronidazole is also slowly, steadily increasing. So in many centers, they think that it is time consuming. The performing the anaerobic culture and the resistance is time consuming and it requires strict anaerobic condition and also requires the expertise also. When one should perform the anaerobic susceptibility testing? Whenever we come across serious and life-threatening conditions like brain abscess or endocarditis or persistent or relapsing infections if it is seen, or those infections which require long-term antimicrobial therapy like prosthetic joint infections and the cases where you do not have any data of the susceptibility of the organism. Also, in cases where a known pattern of resistance against the antimicrobial agent is seen, or if you are having any difficulty in making the empirical decisions, or if you are isolating any of the organisms from the sterile sites. Sometimes we do come across some of the virulent anaerobes with the unpredictable susceptibility patterns, like if at all if you are isolating Bacteroides, Parabacteroides species, Prevotella species or Fusobacterium in culture, it is always better to do the AST for those isolates. And also the AST can be done as a part of surveillance testing. There are different methods available for performing the AST. Agar dilution is considered as the gold standard and we have a document called as M level document from CLSI, so which we need to follow if we are performing the uh, antimicrobial susceptibility testing in anaerobes. So apart from agar dilution, we do have broth microdilution, E-test method and disk diffusion. So disk diffusion method has been proposed in 2022 by UCAST. So where they perform the disk diffusion against the rapidly growing anaerobes like Bacteroides species, Fusobacterium necrophorum, Clostridium perfringens, and Prevotella species against certain antimicrobials. There are some studies which also highlights they have come up with the multiplex PCR identifying different genes which are responsible for the drug resistance. So whenever we come across the mixed infection, it often dictates the therapy. So in case of mixed infections or complicated infection, piperacillin tazobactam and carbapenems in combination with metronidazole can be, or in combination or without combination of metronidazole can be used to treat this complicated infection. But we do have to remember clindamycin is not a reliable therapy for the because there are a lot of resistance cases being reported. So future perspectives, there is need for more surveillance from the lower middle income countries, and also one has to look into the genomic sequence of resistance genes, and also there is need for rapid PCR assays which are specifically meant for some specific gene, so which is not in routine practice now. To summarize, anaerobes may not be in the spotlight, but they significantly impact the disease and resistance. Anaerobes are showing steady rise in resistance, particularly in clindamycin, which may be avoided. So we have discussed global resistance data among different countries, among different organisms also. We have seen that susceptibility rate varies from species to species, between region to region, and even between the hospitals in the same region. So this highlights the call for our own antibiogram. And also there is need for testing the isolates which we are isolating in from the sterile uh, conditions, like if you are isolating it from the joint fluid, etc. So, and also there is need for more of outcome based studies should be planned in future. Anaerobes may not always make the headline. Don't ignore them. They might be the hidden key to successful treatment. As clinical microbiologists, our responsibility is not to let them go unnoticed. Thank you for your attention. I would like to thank the organizers, Don Whitley Scientific, for giving me this opportunity to be part of their clinical microbiology webinar series. Thank you.
Hello everyone, and thank you very much for joining our webinar today. We're now in the live question and answer session. So first of all, thank you very much to Dr. Shenoy for a really interesting presentation. It's dealt with some really fundamental issues which are of great interest to us, and I think very relevant to a lot of our customers because it reflects what they are using our anaerobic workstations for. And we do have some questions for you now. First one, which you've talked a lot about levels of resistance in different anaerobe species, but can you tell us which guidelines were used for assessing that resistance, for example, the UCAST or the CLSI breakpoints or some other source?
We use CLSI breakpoints in our setup.
Yeah.
Because UCAST mainly emphasize on using fastidious anaerobic blood agar, anaerobic agar with the horse blood, which is the availability of that culture media is not there here in India. So we are dependent on CLSI guideline.
Okay, thanks very much. Yeah, I suspected that would be the case because of it being the gold standard method and having the most data also. Yeah. Another question here is, what do we need to do to support increased antimicrobial resistance surveillance in lower to middle income countries?
Yes, we need to perform more of surveillance studies in the lower middle income countries, because here if you look at the different centers, the resistance rates are it is quite huge in certain centers, whereas in our setup the metronidazole resistance is quite less only. So we need to have proper facilities actually. So to do the surveillance testing, one has to have a good anaerobic setup. So where we need to have the expertise, like expertise person, like who can perform the susceptibility testing in their setup, and also like the guidelines. So the person should know properly what guidelines to follow, what are the methodologies to follow, which agar to use, and how to interpret the AST. That becomes very important.
Yeah, of course, standardization of the methodologies is absolutely essential to ensure the data is meaningful, of course. Some more questions here. So you talked right near the beginning of your presentation about the use of metronidazole as an empirical therapy, but given the rising resistance we're seeing, do you think that is still appropriate, or what should be the usual empirical therapy now?
So metronidazole still can be used as an empirical therapy because the resistant rates are not as high as clindamycin. But
Yeah,
one has to keep a watch, like they have to perform the AST in their setup, and they have to know the local antibiogram.
of
So what
course.
is their resistance? That has to be, one has to watch for that.
Okay, thank you
But
very
still
much.
metro can be used.
So another question, you've just mentioned the antibiogram locally, but questions popped up here. Should we perform cumulative antibiogram reports for specific anaerobes in a specific institution?
Yes, we can do that. Multicentric studies, like how in Europe and all, they're coming up with a multicentric study where they pool the isolate, they perform the AST, and they produce the antibiogram. So that will be very essential. Like that would be very good if you perform this. The multicentric studies can be performed.
Yeah, of course. Thank you.
Especially maybe the bacteroides, bacteroides group of organisms are known to be more resistant actually. So you can consider certain group of organism and you can perform the multicentric studies.
Okay, thank you. Is there a role for combination therapy to prevent the emergence of resistance in anaerobes?
Yes, combination therapy can be used because most of the anaerobic infections are polymicrobial in nature. Polymicrobial means it can be one aerobe, another aerobe, or one aerobe or two anaerobes. So if the aerobic organism is a multi-drug resistant or extremely drug resistant, in such cases, you need to have coverage of the antibiotics. So the antibiotic should act on both the organisms. So combination therapy can be used, like, you can use metronidazole along with the ceftriaxone in some cases, or if you are using piperacillin tazobactam along with the other, cephalosporins, that also can be used. Meropenem alone can be used in complicated cases also.
Okay, thank you very much. Talking about resistance again, how reliable is molecular detection of resistance genes in predicting phenotypic resistance?
Pardon? Come once again. Can you
How
repeat the question?
reliable are molecular methods in predicting actual phenotypic resistance?
Molecular methods. So, like, it is always better to do phenotypic resistance, determination of phenotypic resistance also in your setup, because alone molecular resistance detection alone may not, fulfill the criteria. Because see, especially in my presentation had mentioned there are, presence of some silent NIM genes. Silent NIM genes means if you do the phenotypic AST, the particular organism may be susceptible to metronidazole. But still, when you do the molecular, assay, so NIM gene may be present on them. That means, so if you give the metronidazole today to that particular patient, it may act today. But, repeated exposure to metronidazole, the same organism may develop resistance in future. Therapeutic failure can occur. So that's why, so it is always better to do phenotypic resistance also, and to cover up even genotypic resistance determination also can be done.
Okay, thank you very much. And another one here, can you tell us your knowledge of any automated systems for anaerobic susceptibility testing?
No, there are no automated systems are available for anaerobic susceptibility testing, because anaerobes are, they die if you expose them to oxygen. So that is the main drawback, so that's why there are no automated systems available for determining the AST in anaerobes.
Okay. Do you think the international guidelines need to be updated at all to include regional resistance trends for anaerobic species?
Yes, definitely it has to be included, because if you see the the international guidelines and all, they more stress upon aerobic organisms only. Till 2025, they are stressing mainly on aerobic organisms. These anaerobic organisms are getting neglected. So international guidelines should also give emphasis on anaerobic organisms also.
Yeah. Okay. Yeah, I'd agree. Thank you very much. And then just one more, coming back to the fundamental methodology issues that you've been talking about here. How would you advise people to ensure proper sample collection and transport for anaerobic culture in their labs?
See, our main aim when we are suspecting any anaerobic infection, our main aim is to prevent the exposure of the oxygen to the particular sample. First of all, so if you're collecting the sample, make sure that you collect the right sample. So right sample means it's always better to go for pus aspirates. If it is a deep-seated infection, go for pus aspirates or soft tissue samples. So after, attaining proper aseptic precaution. Aseptic precaution is very important because, as I mentioned, these anaerobic organisms are part of the normal flora. So whenever there is some breach in the normal flora only, these organisms will act like opportunistic infection.
Yeah.
In such cases, so our main aim is to prevent the contamination with the normal flora and collect the right sample and make use of the transport media or reduced state media like RAS medias can be used. So as I mentioned already, like in our setup, like we don't have the transport media because it is very expensive. So we use Robertson cooked meat broth. So as soon as we are providing the the Robertson cooked media broths bottle to the clinicians itself, like where if at all if they come across any emergency, surgeries or somewhere, like if they're taking the sample in the OT or in the bedside itself, they will inoculate the sample in the RCM. So that will help us to, getting better isolation rates of the anaerobes in our setup.
Yeah, of course. Thank you very much. I don't see any more questions popping up, but there's one here which might be our last one, a more general question. Do you know of any new antimicrobial agents in development that will specifically target anaerobes?
One was there, as I mentioned in the quinolone group, there was one citalfloxacin.
Yeah.
Citalfloxacin, when I went through the literatures, citalfloxacin is known to have anti-anaerobic activity. But as I mentioned already, there are not many literatures which are supporting, like they have not done a lot of studies on this. Even fidaxomicin also being tried on Clostridioides difficile also. So in here, mainly in our Indian setups, we look for mainly vancomycin, etc., for the susceptibility of Clostridioides difficile. But in foreign countries, in abroad and all, they're making use of even fidaxomicin for susceptibility testing for against C. difficile.
Yeah. Okay, thank you very much. There's also, I should say to everyone, there's some very useful information popping up in the comments. Just one I'll pick up on to finish here, that the CLSI antibiogram for anaerobes will be updated in the 2026 CLSI M100 document. So that's one to look out for.
That's nice.
Okay, I don't think there's anything else. So thank you again, Dr. Shenoy, for a really informative presentation and discussion. And of course, thank you to everyone in the audience who has tuned in today. And of course, this will be also available as a recording after the event. So thank you, everyone.
Thank you. Thank you, everyone.